Okay, let's get started right at 10. We want to welcome everyone to the first presentation in our new AIMS quarterly webinar series. The first one is Billing Collaborative Care Codes, Experiences from 3 Health Systems. Our goal with this webinar series is to highlight the work of practices that are using the collaborative care model and to share real-life experiences and best practices around this work. I am Deborah Morrison from the AIMS Center. The AIMS Center helps support organizations to implement the collaborative care model. And we do that through health system practice coaching and clinical training of collaborative care team members. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. And I am joined today by my AIMS colleagues, Sarah Barker and Christy Malmstrom. Thank you both for being here. This call is being recorded and we'll be sending out a link to the recording and the slide deck to everyone who registered. And today this webinar format is accommodating our large audience. So you'll see on your Zoom screen that there is a Q&A function that we're asking you to use instead of the chat. And please enter your questions for the presenters at any time, but we're saving we'll answer the questions at the end of all 3 presentations. And today we'd really like you to focus your questions on the experiences of these expert presenters. And if you have general questions about the codes or financing, please bring those to our financing office hours or check the FAQs on our website. And we'll be putting links to both of those in the chat for you. And we'll have them at the end as well. By the end of this session, the participants should be able to understand the options for billing workflows using the collaborative care codes, describe the benefits and challenges of billing these codes, and feel more confident about advocating for their use in your organization, and be able to identify resources available to help with collaborative care billing. I'm going to start by running really quickly through the basics of the CPT codes for billing collaborative care. And a couple things to note for any of you who are from FQHC or RHC practices that are using the G0512 code. Most of the information in this webinar is still applicable to your setting, but not all of it, since that code has some different rules, which I'm sure you're aware of. And I'm using the Medicare rules for billing these codes as the standard, but keep in mind that some commercial payers and most state Medicaid plans may follow slightly different rules and have different payment amounts for sure. The CPT codes for billing the psychiatric collaborative care model are a set of 4 codes that are used for billing services in a calendar month. The codes follow the standard time-based code rules of needing to meet 50% plus 1 minute for each time designation. So 99492 is used for the initial month and requires 70 minutes of service, or a minimum of 36 minutes in order to bill it. 99493 is used for any subsequent month and requires 60 minutes of service, so a minimum of 31 minutes to bill. 99494 is a 30-minute add-on code that can only be used with one of the first 2 codes. This code can be added once the full minute requirement has been met of the first code, plus at least 50% plus 1, or 16 minutes of additional service. 2 of these add-on codes can be billed in any month. And again, you must meet the full complement of the base code and the first add-on code, plus at least 16 minutes of additional service. G2214 is a newer code that allows you to bill for a minimum of 16 minutes in any month when the requirements for billing either of the base codes haven't been met. For example, if you identify a patient on the last couple days of the month and there's only time for a warm connection visit and a psychiatric consultation, and all of that doesn't add up to 36 minutes, then you would use the G2214 code, as long as there were at least 16 minutes of services. And in the following full month, you would work to reach the threshold for the 99492 or 99493. The payment amounts are shown for an office setting as well as hospital or facility setting, and I highlighted the office setting ones there. The codes have a variety of characteristics that make them somewhat unique. First, they're billed as Incident 2 under the medical provider, who is providing general supervision to the behavioral health care manager and psychiatric consultant, meaning the billing provider doesn't have to be present while the services are being provided. The codes are billed for services provided by the care manager during a calendar month. This is important because the time spent by the PCP and the psychiatric consultant don't count towards the minutes requirements, but are accounted for in the RVU valuation of the codes. The behavioral health care manager does not have to be licensed to bill Medicare independently, or really licensed to bill any payer independently. So there's much more flexibility in staffing choices than there would be when there were billing standard psychotherapy codes. The codes allow billing with any behavioral health diagnosis that's included in the DSM-5, including substance use disorder. And finally, they may be billed in the same month as traditional psychotherapy codes are, as long as none of the minutes are counted twice. The codes pay for both direct and indirect services, such as brief visits that are under 16 minutes, such as a warm connection engagement visit, phone calls with the patient of any length as long as they're for clinical purposes, care coordination and communication between the care manager and the CoCM team or other behavioral health providers that are involved with the patient, psychiatric consultations for an individual patient during the systematic caseload review session, and time spent managing a registry, including entering patient data or preparing for systematic caseload review sessions. Finally, your care model requires having certain ongoing elements in order to bill for these codes. And here we're paraphrasing both the CMS guidance and the CPT codebook. Your program must have engagement and assessment of patients using validated measures, resulting in a treatment plan. You must have weekly systematic caseload review with the psychiatric consultant and treatment modifications as needed. Use of registry to track visits and outcomes. Ongoing collaboration with the PCP and other treating providers. Provision of brief evidence-based behavioral interventions, outcome monitoring using validated scales, and finally, relapse prevention planning in preparation for completing an episode of collaborative care. So that was a quick overview, and so let's get to today's presenters. We invited all of today's presenters because they have really solid experience with billing collaborative care codes and getting paid for them. Some of them have been doing this for as long as 5 years, and others are more recent adopters, but they've all figured out sustainable and successful ways of doing this within their large organizations. So with that, I am going to hand it over to Angela Kypriatis, our first presenter, and to save time, I will let her introduce herself.
Hello, can you see me? Hi. Okay, hi everybody. Angela Kypriatis. As Deb mentioned, thank you for having me with Allegheny Health Network in Pittsburgh. We have a large footprint though that covers not just Pittsburgh, but large parts of southwestern and northwestern PA. So I'll go ahead and get started here. So yeah, I can mention the health system. You know, the size of our system is pretty large. I'm in primary care, so even though my title is deceiving, behavioral health and social services, I live in the primary care institute of our organization. We do have cross institute, work in this area. So primary care and some of the medicine institutes started this work back in 2018 or a little bit earlier. And then it's grown significantly since then. So we have the Primary Care Institute, Medicine Institute, Pain Medicine. We have a few clinics in pain medicine, as well as pediatrics, which is a little bit newer for us. So go ahead. So our primary care sites are a lot of them in some of the larger cities like Pittsburgh and Erie, but then we have one rural health clinic. So that's newer for us as well in Corey, PA. We've done waves of transformation in different groups of primary care. And so we still have 20 more clinics to go to integrate. But we are, like I said, geographically spread out across Pennsylvania. And then our panel size is about 6,000, and we've modified this a little bit in different areas, but for the most part, that's kind of a general kind of guideline for us, the 6,000 panel for one full-time BHC. So we have smaller offices, they often share if they're in a close geographic area. And the BHC caseload is about 35 to 50 active patients. It doesn't mean they're not getting new referrals all the time, but those are patients they're consistently following in the moment, and then when those close out, taking on new patients as well. So I like this graphic just because we do team-based care, and so you can see that the behavioral health consultant, which is what we call the behavioral health case manager, sits among the team with the entire group of other professionals in the practice. So you have medical assistants and dietitians and pharmacists, physicians and RNs, and just that wide variety of roles that work together. And so that BHC is just one of those team members. Go ahead. Why did we choose these codes? And that's a good question, because we looked at a lot of different models. We looked at the VA, we looked at Kaiser, we looked at I remember doing lots of research on all the variety of different work that was being done out there and had been done across the country, and really we needed a sustainable funding mechanism. So that was an easy way to kind of identify the collaborative care model with the new codes that had just been introduced by CMS at that point. We didn't want to independently credential the case managers either, because we knew that a lot of our patients then might not be able to access. So we wanted to be able to provide services to everyone that the provider, the PCP, could see. And we knew if we were billing incident too, that would be a good match. We wanted to be able to have the flexibility of hiring both LCSWs and LPCs, because I know that in Medicare, especially if you try to do psychotherapy codes, LPCs weren't able to do that. So really looking for some flexibility in who our hiring pool would be. We also knew the co-pays were pretty low from what we could find with these codes. And then the only problems we really run into there is the high deductible plans, but a lot cheaper usually than a traditional psychotherapy code where you're charging for each session. And then in Pennsylvania, we're pretty lucky, and that's not true for all states, but Medicaid does reimburse for these codes for us. So that was a good selling point as well. Go ahead. So our workflow, we had to work with our billing and coding team, and we introduced these codes to them. They had never really heard of them before. They'd never been used in our entire health system anywhere. And so we gave them the CMS tip sheets that were on the AIMS website and that we've been introduced to. And they did the research and then confirmed for us that yes, these are legitimate codes that we have, and we need to. There was some work in trying to get them into our contracts. They weren't in all of our contracts initially, but so we just kind of had to work through some of those. It took a few months to kind of work through a lot of that. And then we started training some of our initial staff that we had on these codes, because we did have a few staff who were in the role, but who weren't billing at all at that point. And we worked with our billing team to drop dummy codes in Epic. We use Epic as our medical record. And then they were there, adding the minutes for the month total at the end of the month, looking at that special work queue that's just for collaborative care. So really was creating a special work queue just for these codes that only a few of their billing and coding folks had been trained on and understood. And then they dropped the appropriate code at the end of the month based on that total. Okay, go to the next slide. So our documentation, I said, like, we worked with the folks in the billing team. We had to make sure that as they were reviewing the codes or adding up codes for the totals for the end of the month, they were making sure also that we met the criteria. Was there an evidence-based tool documented in the notes, or, were all the pieces in place that were required? And so that's a really good quality piece as well for us. We can use smart phrases and added smart phrases for physicians to be able to, document that they had discussed this with their patient and that the patient was agreeable to meeting with the BHC. And then we have also smart phrases for the BHC to document that they had discussed the cost sharing and that, the physician had referred them and what their condition was that was the reason that they were referred and that kind of thing. And we do have a good quality improvement process in place now to conduct peer reviews. That's more newer process for us, as well as the supervisor reviewing, doing random note reviews as well. You can go ahead. Our revenue goals, I think everyone's goal is to break even. We never expect to make money in behavioral health or social services. We just want to break even. And so we're not quite there yet, but we do have a handful of clinics who are breaking even. And we're always reviewing patterns to see if is it payers, is it the physician buy-in, is it that they're getting more referrals, still trying to figure out those patterns. But we do have all of our clinics coming in at least at 75% now to cover the BHC salary at about 75%. So that's a big success for us. We didn't know that we would even ever get there, because even in our traditional behavioral health departments at AHN, I know that's a struggle as well. So anywhere in the system where you're doing this type of work, it's always been a struggle to break even. So we're happy that we're there, but we're not done yet. So we're hoping to be able to break even at some point. Obviously different payers, different clinics and different geographies look differently, who their payers mix it, do they have more Medicaid patients? Do they have more Medicare patients? Do they have more commercial? That's always an issue as well to look at, because, our payers don't pay the same rates. And to reach the goal, we would need all the payers to pay at least the CMS rate, which Deb showed earlier, and that's the gold standard. And so that's really seems to be a simple goal, but for some reason it's not as easy to achieve as we would like. But that is really what we're advocating for. And no copays would increase patient participation, because we do have patients who decline services sometimes when they do find out there is a copay. And payers have to keep up with the increased cost of living. So as you all know, we've gone through a pandemic, and employees, cost of living has gone up. Employees, we're giving employees raises, right, and giving them cost of living, but our payer contracts don't always keep up with that. So that's really an issue that we want to keep advocating for as well. Go ahead. So the benefits and challenges. So not juggling different code types has been a benefit for us. We know that a lot of folks are still having to juggle like psychotherapy codes and collaborative care codes, and we just wanted to try it with just collaborative care and see if we could make it work, because it really does get complicated with, then you have to create treatment plans and are doing meeting other types of criteria, different session lengths of appointments and all that kind of stuff. So we really have been able to stay with just using these codes only. The exception, I guess, would be we do use the 99484 for behavioral health integration when we don't hit the 30-minute and hit the 20-minute threshold. Providing care under the medical billing has been a benefit for us, because in Pennsylvania we have a behavioral health carve out, and so that billing is different and is a different benefit for patients. And so we appreciate that we can keep it all under the medical side, and that's been really helpful. Allows us to expand to additional clinics and areas. So we've loved that we've been able to use these codes that have been successful, and that we've then been able to, expand that out into other parts of our system. Challenges, I think not all payers recognize. All the large ones do, but we still have some smaller payers that are not as common, that don't know what the codes are, and when patients call or when we call or help advocate on their behalf, they're like, we're not using that. They need to use their behavioral health benefit. Like they just don't understand why you would be doing behavioral health stuff in medical world. And patients with high deductible plans, often they haven't met their deductible. They're hesitant to participate. Many payers still don't reimburse at the CMS rate, so they're coming in under or significantly under the CMS rate. And manually dropping codes is labor intensive. So although our clinicians aren't doing it themselves, we do have people who's, this is a part of their job, that they're manually adding up these codes at the end of the month from the special work queue, and that's labor intensive, so not ideal. Go ahead. And what else is important to share? I love this graphic because in our health system is something we had to create when we started having conversations with our Psychiatry and Behavioral Health Institute department, because we work together and we share some of the same patients. And so we were trying to figure out what is a level system, a step system, if you will, to what is the lower level of care, and something where a patient might just need some self-help or support group kind of information, versus somebody who's kind of coming in at behavioral health consultant level and is willing to engage in that area, and maybe triaging them to a higher level of care. So I'll move on because I know we're short on time here. You can see that it progresses up to, psychiatric inpatient treatment. So I know we're gonna have questions later at the end. So that's it for me. Thanks, guys.
And I will pass this over to Jen and Cheryl and Shannon.
All right, sounds good. Well, hi, everybody. Thanks for joining us today. My name is Jen Thomas. I'm a family med physician and PCP champion for collaborative care and integrated behavioral health director at Morris Hospital. I'm joined today by the real rock stars of my team who get everything done in the billing realm of collaborative care, which is Cheryl Jans, LCPC. She's one of our care managers that's been with us from the start. And then our coding guru expert, Shannon Gesquire. So I'll describe a little bit about what we're doing at Morris Hospital and then kick it over to them for some more details. All right, so Morris Hospital and Healthcare Centers. We are an 89-bed independent nonprofit health system that's kind of on the edge of Chicagoland. We're rural, we're about hour and a half southwest of Chicago. So our main hub campus is Morris, where the hospital is located, and then we serve lots of smaller communities surrounding the city of Morris, Illinois. So we serve a pretty big geographical footprint, 5 counties, 19 zip codes. We've got 37 primary care providers and 25 primary care locations. Out of those, we have collaborative care model going at 8 of those locations. We're real proud of that. We started doing collaborative care in February of 19, so it's grown quite a bit just in a few years, even during the pandemic. So a lot of good things happening there. Next slide. All right, so what does our program look like? So integrated behavioral health is the arm under which we've developed collaborative care. So this is a primary care offering. Medical director FTE and clinical manager FTE are shown there. We have 16 PCPs that are trained in collaborative care and referring patients into the model. Our care manager workforce is a 3.3 FTE, so a couple are not quite full-time, but we have 4 care managers. And for each care manager, their caseload size, again, for a full-time care manager, 1.0 FTE, approximately 70 active patients, give or take, depending on your patient population. And then we employ 1 psychiatric consultant. She's a 0.2 FTE who is remote. She works with us from Arkansas. She's part of the telemed company that works with our health system, and she's been a wonderful champion and a really great psych consultant that's taught us a lot about primary care psychiatry. So next slide. All right, so Angela covered a lot of this. I won't bore you with repeating all the good whys with collaborative care. I'll just try to throw in a few extra points of view from us at Morris. Collaborative care, it's an excellent evidence-based model. There's a huge amount of, I think it's like 90+ randomized trials now showing that it does help improve quality of care and outcomes more than just usual care. If me as a PCP just hands a patient a referral to go seek behavioral health outside of the organization. We have chosen to do collaborative care codes because we're trying to standardize that billing workflow. As Angela mentioned, with the workforce of who can serve in that care manager role, when it's collaborative care codes, we can have different licensures, different backgrounds and experience of behavioral health folks being the care manager, teaming up with me in the primary care space. If we're limited to psychotherapy codes, then it matters more if that care manager is, say, an LCSW versus an LCPC. Angela mentioned there's rules with Medicare where LCPCs cannot bill Medicare, the psychotherapy codes. So essentially from that, let's build the workforce lens, it helps to have a wider population of who you can recruit, who you can get in that care manager role to help the PCP in your organization do even better behavioral health care in the primary care space. Next slide. All right, so the billing workflow, Cheryl, I don't know if you want to jump in and talk a little bit about what you do. Cheryl does the billing. I know big organizations, they might have someone that does it for them, but Cheryl does the work. She's the face of care manager and does the coding end of month. So I don't know, Cheryl, if you want to kind of buzz us through your usual steps for this, go for it.
Sure. This is Cheryl Jans. I've worked here for about 3.5 years now. I was kind of the guinea pig as far as I was the first care coordinator that kind of started doing the billing by myself. You know, we were in a meeting, billing used to do it, and they asked me if I wanted to take that on. I was like, sure. So I've been doing it for quite some time now. It's to the point where all of us now do our own billing each month. It's a matter of just kind of, we use the CHAMP tracker, you know, through AIMS to document each visit. And at the end of the month, I kind of go through, add up the total minutes, and then bill accordingly. So it's a pretty efficient process. It's just, like I said, it's just a matter of, you know, keeping track in the tracker, which we use anyway to document all of our visits. And then at the end of the month, going in, adding up, and then billing for each patient according to how many minutes they use during that month.
Excellent. That's great. Thanks, Cheryl. And it's not too timely. You feel like it's okay to, you know, you're still getting plenty of time for patient
Oh,
basic
yes.
care.
Yes.
How much time do you chunk off? A couple hours?
You know,
end of month,
no,
or?
not even. It's hard to say.
Sure.
You know, it varies. I know I have been getting more CoCM patients now. My list is growing. So, and I do it kind of in chunks, I guess. So I don't know if I had to say, if I just sat there and did it, maybe at the most like 45 minutes to an hour, I think.
No, that's excellent. That's great. Great perspective. Thank you. Okay, great. Next slide. And then Shannon, I don't know if you want to speak a bit to our EHR documentation and billing workflow. Feel free to jump in. I don't know if you're on mute, Shannon. I'll just, if you can unmute. Oh, are you on, Shannon? You might be having some technical difficulties. I'll just jump in here, and Shannon, if the sound comes back, let me know. So again, as Cheryl mentioned, minutes each month are tracked both in our patient registry. We use the AIMS Center registry product. We're part of some research studies with AIMS, so that's the registry product we use. There's lots of other registries on the market. I've even been told people can use an Excel spreadsheet if that works for you. The coding rep, that's Shannon's job. She reviews the encounter at the end of the month. We at Morris Hospital, we have the PCP do a smart phrase with the verbal consent, where we just cover the basics of CoCM, that it's not free, there's cost sharing involved. And again, me as a PCP, I can just put this dot phrase in my note after introducing collaborative care models, so it's more efficient with documentation. And then the coding person, that's Shannon, would review the encounters at the end of the month. And if there was any documentation lacking, say we forgot to get the verbal consent or what have you, total up minutes, she would reach out directly to the care manager. Okay, next slide. Revenue goals, yeah, kind of as Angela was saying in her health system, break even is our goal. If we could do better than that, that'd be great. But break even is perfectly fine. We've learned from looking at our revenue that we needed to standardize too our billing workflow for screening. So our PCPs do a lot of universal depression screening, but we weren't uniformly coding for that with, say, a 96127. So our coding department has helped do some great training of the PCPs of, well, how often can I put a behavioral health screen code in that 96127 if I'm doing a PHQ-9 annually? So that's a good opportunity to help increase revenue for your program as well. Timely financial analysis, it's been a challenge for us. We're a small health system, we wear a lot of hats. So I'd like to get to a place where we can look in real time at what our cost and revenue looks like. I think that's something we're going to try to aspire to in the near future. Next slide. Benefits and challenges. Again, benefits, it's nice to have one billing workflow. If you have to, like we did, use psychotherapy codes for our Medicaid patients because Illinois Medicaid wasn't paying the collaborative care codes, and then CoCM codes for private pay and Medicare. It just makes things a little confusing. So it'd be great to have one set of codes for all patients regardless of payer. And again, having that funding mechanism to work toward financial sustainability. If collaborative care is something that's going to help a lot of health systems do really great primary care and IBH, there has to be a funding mechanism to support that work. Challenges that we've seen, we still feel like the at least Medicaid rate in Illinois is relatively low. So I think we'll be working on some advocacy to increase that over time. We're just happy it's getting paid at all. And again, that time investment that the care manager takes to have to tally up for minutes at the end of the month is a potential con, but we're still making it work. Next slide. All right, benefits and challenges. So Illinois Medicaid, we have an interesting story with collaborative care codes. So Governor Pritzker signed Senate Bill 2085 into law that was to take effect Jan 1, 2020, and we all celebrated and got some good press too. Here's the APA Psych News. Illinois becomes first state to pass APA's model collaborative care legislation. So great news, it's in the books that Medicaid should pay for collaborative care. However, it wasn't on the fee schedule. So this was kind of some grassroots pulled together with the local coalition, folks like Jim McKenzie and folks from Advocate Health System Illinois. In April 2021, we pulled together some stakeholders, people from Illinois Hospital Association and Kennedy Forum Illinois, some local lawmakers, and said, hey, we're trying to do this great thing called collaborative care, and this law says that Medicaid will pay for it, but they're not. It's not on the fee schedule yet. So it took some, networking with, again, those local partners to say, hey, we need to, make sure that those codes are actually turned on and on the fee schedule so we can actually bill for it. And happy to say that that has come to pass. So the collaborative care codes are on the Illinois Medicaid fee schedule. Just happened in August 2022. So really excited to get to, again, narrow down our coding and billing workflow to use just those codes. But again, that was a lot of local partnerships and relationships that helped that become a reality in Illinois. Next slide. What else is important to share? We'd say, get to know your coding team. If you're in clinical work, you may not have a personal relationship with the coder billers at your health system, but they might be your new best friends to help you figure out how to wrangle this beast and get these workflows down. Again, that networking with other folks in your state and region, and advocating if your state Medicaid does not pay for CoCM, you might have to do some of that, networking and advocacy work. And then building that strong collaboration with your Medicaid or possibly MCO rep. We in Illinois, we have to do a attestation form. So we've just started doing this. I think a couple weeks ago, we turned these in. So we say we intend to pay or bill for CoCM. We have to show this attestation form that we use the model. Here's the provider doing it. So just another, hoop to jump through. But, these are just some of the barriers. But I think we're getting close to making it a reality, especially for our Medicaid patients, which is really exciting, a long time coming. So we'll let you know how it goes. All right. I think that's all from the horse team. Yeah, thank you.
Congratulations on that. That's great.
Great. Yep.
Okay.
Thanks.
Thank you. Now we're going to move to SCL Medical Group, Wendy and Sarah, and take it away.
I think go to the next slide. Sarah and I are both in day-to-day management of a behavioral health clinic with 2 psychologists and 4 LCPCs. That's part of the St. Vincent system. You can see from the entire system that we have 54 primary care providers. I don't know how many specialty providers we have, but they've all been seeking behavioral intervention for their patients. And in the beginning, our goal was to integrate collaborative care in 6 clinics, and we have now expanded to all of these clinics. Next slide, please. And we started in 2018. In the beginning, we collaborated with AIMS. We still use AIMS as a resource. When we have a new provider onboarding, I always refer to AIMS and their wonderful website for any kind of information that anybody might have. And we chose the model because it allowed us to provide behavioral health resources in primary care, because our behavioral health clinic is, we've got probably a 6 week to 6 month waiting list for people trying to access behavioral health. The patient-centered team care was important to us. It's improved patient-doctor relationships. Again, allows better access to resources. And additionally, it has allowed us a larger hiring pool. We recruit MSWs, LCSWs, and LCPCs. Generally, our providers are MSWs who can bill easily under the Incident to model. And again, we have licensure limitations. As Jen and Angela referred to, LCPCs cannot bill Medicare. So using collaborative care codes allows us to bill. I'm glad we don't have the same issues that Illinois had. We are seeing a higher reimbursement rate using the collaborative care codes versus the traditional psychotherapy codes. Next slide.
Okay, so the billing workflow is similar to what everyone else already stated. Our billing is done at the end of the month. Each individual encounter throughout the month is given a no level of service, and then it's all added up at the end of the month. Our billing is actually completed by our behavioral health providers in each of their individual clinics. They do have the support of our coding team, but they do the actual billing. They block time in their daily schedules to complete the billing. As we all can see from what was said previously, it's several steps to get it completed. We do utilize the AIMS caseload tracker for the monthly minutes. They enter their encounters throughout the month, and then at the end of the month, they go back to that page that adds up the minutes for them, and then they can easily see which clients they can bill on for the month. We do bill in the EMR through Epic. Our providers utilize episodes of care so that all their encounters throughout the month are linked together and easily accessed in one click. And then they bill out through a care coordination encounter, noting the time that was spent and the method of the visit, whether it was face-to-face, virtual, phone, the time spent with a psychiatric consultant, and collaboration with the PCP. And we do utilize smart phrases to make that easier on them in the billing. And then of course we do bill out the incident too. Next slide.
Our workflow includes, in our EHR documentation, begins with every encounter added through our patient scheduling. So we use Epic, and it's a pretty robust EHR that allows our providers to link each visit with a billing encounter, if possible, if we need to. We use the feature in Epic called Episodes, which creates a link for all our encounters for a month. And that includes face-to-face, phone, telehealth, psychiatric consultations, and collaboration with a referring provider. And all of our care team has access to those notes. Additionally, our 2 psychiatric consultants have access to our EHR, and they are able to document encounters as well. Our progress notes have templates that our IT team built to pull in pertinent information such as PHQ-9, the GAD-7s, to make the documentation easier. And again, like others, we're using smart phrases for consent and cost sharing information. Next slide.
And just like every other organization, our revenue is to be 100% self-sustained. We began collaborative care early in 2018, began billing in November of 2018. By the end of 2019, we were 100% self-sustained. We currently have seven providers providing care, and they're all maintaining their self-sustained or their self-sustainability as far as they're covering their salaries. We are limited now. We would love to add more providers, but space in our clinics is limiting us in expanding just to provide more services. Next slide.
We do have one clinic, our internal medicine clinic, that has had 2 care managers, and we probably have 3 other clinics that would enjoy a second provider, but as Sarah said, there's limitations. So benefits, we can use provisionally licensed providers, the MSWs, the master social worker level provider. And it's added access to services for our community. Billings, it has more than 2,000 mental health providers, but they either don't accept Medicare or Medicaid. So they come to St. Vincent and a provider down the street for those services. It also provides support for our primary care providers who every day when they're seeing a patient for a cold or managing their health care are presented with depression, anxiety, etc. So this allows them a resource for their patients. Our challenges have been the workflow. It's time consuming, having to track the minutes and enter charges manually. Our Epic, I don't know that it can't do it, but we don't know how to do it. We cannot track minutes from encounter to encounter. So we definitely refer to the AIMS tracker to manage that. And the other challenge is that our care managers are spending more time a month than is reimbursable. So they have those challenging patients that just need more time. So it's interesting to try to get everyone to go back to focus on short, brief interventions. I think it's the nature of the provider to want to do more for those patients. Next slide.
And as far as what else is important to share, Wendy kind of touched on it already, but implementing the collaborative care in our primary care clinics has lifted the burden off of our PCPs when they have been overwhelmed with those behavioral health concerns from their patients and don't have the time in their schedule to be able to properly address those. Having that behaviorist in the clinic there to hand off to has been a godsend for them. The incident to billing, of course, again, we've all said it is not necessarily straightforward. There's, you have to make sure all the CSM steps are in there, everything is covered, you have your site covered, you have your smart phrases for your shared billing and all that, that's, make sure that's all in place and is not forgotten. And then the specific codes, the once a month billing that requires the providers to block their time. It's time consuming. They have to make sure they're staying on top of keeping their tracker up to date every day, every week at least, so that when it comes time to bill, they don't have to go backtrack and find that information. And it's more, then becomes more about time management, and making sure they're staying on top of that.
All right. Well, many thanks to all of you for presenting today. It's really valuable to hear from people who are, stepping up to figure this all out, and they're willing to share you're learning with everyone else. We really appreciate that. So now it's time for questions, and it looks like we have a ton of them. Sarah is going to read the questions that were submitted, so then our panelists can respond. So Sarah, are you ready with a few?
Yeah, thanks, Deborah. We got a lot of questions, some that are very general around implementation and financing of the collaborative care codes. So I just want to reiterate, we have put into the chat our office hours where you can come and ask general questions around implementation or financing collaborative care. So I would recommend, I'm not going to read those today. I want to focus on the panelists. I'd recommend going to those office hours for those questions. All right. Angela, there were several questions that came in around kind of breaking even and how many, on average, how many encounters are you able to bill per month or total billable units a month? There's a question about that. And how are you also paying for your psychiatry colleagues for consultations? So maybe if you can talk a little bit more about that, that would be great.
Yeah, so as far as how many we bill per month, so we have a report that pulls from Epic into Tableau, and so we can track. It's different by office, different offices. Some offices do more of the 30-minute, drop those codes and have patients who may not come back until the next month. And some offices have patients who are willing to come back more frequently, and so you'll see a higher utilization of the 492s or 3s. It really varies by office and geography. I think a lot of times. I mean, the pandemic actually with the more virtual support has definitely made things easier for patients who are, couldn't or weren't able to, interested in traveling or coming downtown to some of our more urban offices and paying to park and all that. So that's definitely helped. So I don't know off the top of my head, like the number, but it does vary by office. So be happy to talk to anybody independently about, different payer mixes and which offices are doing. We also find that different offices have PCPs who are more engaged than others, and so you bring this resource to an office and you might have 5 PCPs and 4 who use it all the time and 1 who doesn't use it or doesn't refer. So it really does vary by practice. We found a lot of cultural differences in various different practices. Your question about psychiatry time, we actually, so that is something we're not breaking even on. We're just paying for that from primary care budget. And that is, we have a contract with the Department of Psychiatry, and we're now up to 0.5 of one of their full-time psychiatrists is now 0.5 for just doing collaborative care. So we pay for that just out of our budget. It's just a big selling point, I think, for physicians as well, because we could, as a system, though, it's alleviating some of the burden from primary care. Often was sending a lot of patients to the psychiatry department to try to get patients in to be seen in person by a psychiatrist. And with this model, it's, and as somebody else mentioned, there was, 6 weeks to 6 months of a waiting list, depending on what you needed to see the psychiatrist for. And that availability just isn't there. We don't have enough psychiatrists, and there aren't any more to hire. They're just shortage. So this does alleviate, we're paying for the psychiatry time, but it alleviates the burden and keeps patients within our system, because otherwise you're just trying to refer them out externally somewhere. And the community providers were also booked up. So it solved a problem, even though we're paying for it. Yeah. I don't know if that answers your question.
Yeah, oh, that's great. Thank you. How about this question about, have you encountered any issues with the PCPs struggling to inform the patients of the cost sharing piece? I recently learned over-informing the patient's not good, but I'm curious if your PCPs have found some sort of sweet spot of letting the patient know about the billing structure. And really, I invite any of the panelists to also help Angela out with this question. So.
Yeah, I can tackle that one as a PCP. I mean, it's not perfect. I think we try to give them a, overall sense that, like, when you come see your PCP, there's cost sharing. So if you have a high deductible and co-pays, those same things apply. We don't have such a well-oiled machine that we can say, and this is what collaborative care will cost you out of pocket. I don't know. I mean, that'd be great if organizations have that figured out. I'd love to learn from you. But like all things in healthcare, it's a bit tricky where patient might get billed weeks, months later. So we try to be genuine and honest up front that cost sharing applies. But you know, we hope that the service, like when you come see your PCP, is worth that out of pocket. But yeah, I don't know, does anybody else have a better sweet spot of describing cost to patients? Because yeah, we try to teach our PCPs to just sort of lay it out there that this isn't free, cost sharing applies, but like when you see us, we're hoping that the cost of services is worth it to you. So.
Yes,
We-
as Angela would say, we've done some data polls on what the copays typically are, and we'll say to a patient, the average that we've seen over the past couple of years is, you know, $10 to $40, sometimes nothing, right, depending on your payer. And we will give them the codes to follow up with their payer if they want to check into that more. But you're right, there's no science to it, and it depends on how much they engage in the month. And so I think our physicians, what we tell our physicians to say is, you know, it's been pretty affordable for the patients I've referred before to behavioral health, depending on your insurance, and as long as you don't have a high deductible plan. If you'd like to talk more with our BHC, like they can kind of go into more detail. So the physician really just has like a 2-sentence spiel, and then it's like handing it off to the BHC to kind of go into more detail.
We developed a paper handout for our care managers to give to a patient that explains it, aside from what the medical provider has explained.
Yeah, that's smart. That's a good tip. Like it. Good.
Yeah, great. For the Morris Hospital team, I know there was a question came in about, you know, at the end of the month, putting in the billing takes about 4 hours. Their LCSW, for how many CPD codes are being dropped and how's that workflow work? You talked a little bit about this, but maybe just tell us a little more.
Yeah, Cheryl, do you want to chime in a bit? So was the question how many like claims on average is she, or how many?
Yeah, how many claims? I think you said maybe it was about an hour of time a month, if I'm right. And I think they were just wondering, how does that, how do you drop all those claims so quickly, perhaps?
Well, what I do is as I'm going through and charting throughout the month, I make a list of the patients that I have to bill. So I have like an ongoing list throughout the month. And then at the end of the month, I go into the tracker, add up the total minutes, and then then go ahead and bill. So, you know, as I said, I don't always do it all in one shot. I kind of break it up a little bit here and there. So I'm guessing about 45 minutes to an hour at this point. As I said, the number of collaborative care patients have really increased lately, where, you know, I used to bill for maybe 12 or 13 a month. Now I think last month I had maybe 22 or 23. So like, do you have like
Really
specific,
helpful.
yeah, do you have
Yeah.
specific like questions that I'm not, I just want to make sure I'm answering your
that's
question.
perfect.
Oh, okay.
Yep, that was perfect.
Okay.
And I like how you track throughout the month, so it makes it easier at the end of the month. That's a great
I do that. I mean, you wouldn't have to do that. I'm not sure how the other, you know, I mean, I've trained, well, no, I didn't actually train them, but I don't know how other people do it, but that's just kind of the system that I came up with. So rather than at the end of the month going through my whole CHAMP tracker and be like, okay, is this one collaborative care? Is this one a psychotherapy? I just do it as I'm going along, and then I have my list. That just works for me.
Yeah, and I know there are a couple questions too around what is being used. So when you say CHAMP tracker, you use a AIM Center CMTS
I'm sorry. Yes.
product.
Yes. Correct.
Yes, registry tool. Great.
Yeah.
Okay.
Yes.
And then Morris Hospital, there were two questions around kind of, you had mentioned that you use the 96127 for the PHQ and the GAD. Do you want to tell us? So one question was, how frequently can you bill it? And do you use it each time? Do you want to just let us know?
Yeah, that's an evolving workflow for us. So we know we use PHQ-9. One, in a way, is universal screening. So it's a screener, helps us identify depression. When we're using it in collaborative care, it's that measurement-based treatment to target. So I'll do a repeat PCP or repeat PHQ-9 as a PCP visit. My care manager will do a PHQ-9 at each subsequent visit. Now we're not doing a 96127 each time the care manager does a PHQ-9, but as a provider, as a PCP, I do. Our coders have told us that we can bill typically per quarter a 96127 up to 2 units per visit. So about every 3 months, then if you're doing a PHQ-9 or a GAD-7, you could do 96127 for the PHQ-9 and another 96127 for the GAD-7. About quarterly. Now, different payers will reimburse at different rates. I don't know if Shannon, you want to chime in on this, because that's the thing we've been really trying to look at, of what we didn't want to have large out-of-pocket costs for patients. We've heard of some health systems as getting really sophisticated, where they'll set a low max billable charge for 96127 and then create a billing router so that the PCP doesn't even have to think about it. They just do the clinical metric, and then behind the scenes, the billing gets figured out of, are we billing for this visit or not? So I'm sure a lot of folks are a lot smarter about that than I am, but as a clinician, that's kind of my rule of thumb I was taught, is you could do it about once a quarter, up to 2 per visit. Does that help a little bit?
Oh, thank you so much.
Okay.
We are running out of time. There was a question that came in that I was curious about too, around if any of you are in kind of an RVU environment. So are PCPs compensated for their role in collaborative care? Do they receive RVU payments, or is this waived?
Yeah, they do. So the 99492, and correct me if I'm wrong, we were taught the RVU is 1.88 for the initial collaborative care code, the 99492, 99493 RVU of 2.05, and for 99494, the RVU is 0.82. So again, that would be something to, as providers, if you're doing collaborative care, getting with your leadership and coding billing, if you get your monthly report of your RVUs per CPT code, to be looking at that, because yeah, it's valuable work on your behalf as the provider to do integrated behavioral health. So yes, you should be receiving an RVU for that type of work.
Deborah, are we, where are we at? We have so many more questions coming in.
I know, there's so many more. I hate to.
I want to just put a plug in again for our office hours, because you can bring many of these questions to the office hours.
Yes.
Do you want to wrap up, and I'll see.
Why don't we wrap up, and then if there's any time left, we can answer a few more questions.
Sounds
so good. I've already put up the additional resources here. We do have upcoming quarterly webinars planned for 2023. We have 4 dates set, and they'll be 10 to 11 a.m. Pacific time. And some of our upcoming topics are pediatric collaborative care, those systems where they share the care manager role between 2 people, innovations in registry work. And we'd love you to, in the survey, the evaluation survey of this webinar, we'd love you to share other topics you'd really like to hear about. So we're going to put that webinar survey in the chat right now, and we'll also send it with the slides and recording afterwards. And thank you so much for attending today. And we learning more about how we support organizations with their implementations. And we'd love you to reach out to us if you're interested in having support from the AIMS Center. We have partnered with 2 of the 3 organizations that you heard from today, and we're really eager to help other practices succeed as well. So that's all I have. And we have 3 more minutes for questions.
Great. I'd be curious if any of the practices today are also working, with pediatric adolescents patients, and if there are any kind of nuances around billing or challenges they've come up against with that population. There's a question about that.
This is Cheryl from Morris Hospital. Yes, I do work with adolescents. 12 and up, and we actually just hired a pediatric care coordinator who will be starting next week. But the billing is not any different. So I bill the same. I bill under the PCP, total number of minutes.
Yeah, we are, as Angela at HN, we are also doing pediatrics. We have 1 BHC in pediatrics and hoping to expand. But one of the things we did see, the patterns we saw consistently over the past 2 years, is that over the summer, the referrals go down. So patients, families don't come in as often, I guess, in the summer. And so we see a big drop in referrals in the summertime. So we're trying to figure out, what does the BHC do during the summer, and how do we keep prep billing.
Yeah.
What do we do?
Yeah, absolutely. I'd be curious to know too, with other health systems, are you using, like, for the under 12 crowd, you know, there's the scared, the promise, like the evidence-based metrics for the younger folks, and like, how does that fit into your registry? I know this is getting kind of complex, but you know, those are some of the things that you'll run into if you start caring for children. You know, the adult population, you're used to PHQ-9s. Kids, it's like, oh yeah, what about that 10-year-old? You know, what metric? And is there a column for that in the registry? So these are things we're learning in real time as well. So if you're coming up against that, you're in good company.
Yes, and that's a great question as well for our implementation office hours.
Yep.
All right.
Awesome.
Any other final thoughts from our panelists as you've been talking today, or seeing the questions come in that you wanted to make sure you got in our last minute or so of time while we have you? Any thoughts? Just to reiterate, we will be sending out the slides and the recording. There have been a lot of questions about that. So we'll do that after the presentation. And we also have the survey. So we're curious to find out how you thought this went today, and ideas for future topics. All right.
Yes. Thank you all very much. And thank you so much to our presenters for being the guinea pigs for our first quarterly webinar. You did fabulously. Take care, everyone.
All right.
Thank
Thank
you.
you.
Bye-bye.
Thank you.